Good evening. I hope you guys can hear and see me and also see my screen. Can someone please confirm if you can hear me and see my screen, please?
Yes, sir.
All right. So what we are going to do today is in the next couple of hours, we are going to do a few OSCE stations. So still, I think there's not proper confirmation about what the format is going to be, but we believe it's going to be something consisting of things like observed history taking, things like communication, and things that and stations that would involve clinical examination as well, right? So I'm going to go through some of these different stations today, and so we'll keep this like an interactive session, right? So I need some volunteers to participate, right? So we'll run through a few stations. So we'll start with history taking, all right? So in the previous format, how it used to be was that you would have sort of an observed history taking where the examiner sees you take the history from a real patient, and then you would have to sort of summarize the history you've taken and then answer a few questions. But with the time limitation, it might just turn out to be an observed history taking with a real patient or an actor, right? So we start with an observed history taking. So don't worry, right? So just one of y'all please volunteer. It doesn't have to go right or wrong, right? There's no right or wrong in this. Don't worry. So we'll just see how it goes, and then I'll discuss on what are the steps that you should follow and what are things that you should do, right, at the exam. So this is the patient, Mr. Sarat Pereira, and I'll give you the history, right? So don't worry, it's going to be a very simple history, a very common history that you all come across, right? So we'll time and do it. So within 10 minutes, you have to take the history, right? I'm not going to ask you any questions. I'm just going to be the patient for the next 10 minutes. So take the history from me, try to come to a diagnosis, and advise on what the next step is going to be, like you would advise a patient, right? So what you have to think is just consider yourself a doctor and who is seeing patients at a ward, and that this patient has come to you. So how you would sort of approach and what sort of a management plan would you tell the patient, right? So any volunteers? Don't worry, guys. This is just for us to discuss, right? Just to get things going, all right? So don't worry, just 10 minutes. I mean, you can ask whatever you want, all right? So don't worry. So can someone volunteer, please?
Yes, sir. I'll volunteer.
All right. Thank you. So, yeah. What's your name?
Nipuni.
Okay, Nipuni. So Nipuni, have you read the scenario? Are you comfortable with it?
Yeah, so do I start like from the beginning, like with patient
Yeah.
particulars and everything?
Everything. So this is a fresh patient who has come to you. So what happens is usually outside the OSCE station, there will be a small card, right? That's how it usually happens. And there'll be something like this. It might even be longer. But just because they give you the name and all that, don't assume that you know it when you go in, right? So you have to treat the patient as a fresh patient who you just met. All right. So I'm going to time, right? And I'm going to tell you when there's 2 minutes left. So that's probably when you should start sort of finalizing things and sort of think about a management plan and all that and tell the patient, right? Remember, you're not advising the doctor, right? You're advising the patient. Okay. All right. So 10 minutes. Okay.
Okay.
All right. Good to go.
Yeah, good to go. Is
All right.
English fine?
Yeah, English is fine. Yeah.
Okay.
Okay. Start.
So good evening. I am the house officer of the medical ward. What is your, may I know your name, please?
Yeah, I'm Sarat Pereira.
And how old are you?
I'm 50 years old, doctor.
Okay. And can I know what you do for work?
Yeah. So I'm an engineer.
Okay. And you have kids, you're married?
Yes, I am. And I have 2 kids.
Okay. So what brings you to the medical ward today?
So doctor, I got this really bad pain like across my chest. So I went to work today, and I was going to a site, and then I got this really, really bad pain, and I got really scared, and I came to the hospital.
So can you describe where exactly the pain is? Is it more towards the center or is it towards?
Yeah, it's sort of somewhere like towards the center. Yeah.
And did it happen all of a sudden, or did you feel it build up over time?
I saw it all happened in like within a span of about 5 to 10 minutes. I mean, I felt it coming, and then it got really bad.
Okay. And what kind of pain is it? Does it feel like it's constricting you? Does it feel like it's stabbing you?
No, it was like someone was pressing my chest from out. Like it was sort of,
Someone with
yeah,
pressure, like pressure.
it just got very tight.
And is there like any, does it help if you sit down or like when you rest, is it worse? Like, is there anything that,
So I immediately sat down, and I mean, I felt like it got a bit better, but it didn't really go off.
and is it like radiating to anywhere? Is it radiating to your arm, your
Uh,
neck, anywhere? Do you
you
feel it
mean
in other?
you mean does it go anywhere else, doctor?
No, do you feel the pain in somewhere else
Yeah, yeah,
as
I
well?
also felt it. Yeah, I also felt it on my shoulders and my neck as well. Yes.
Shoulders and neck. Okay.
Yeah. Yes.
And so this has been going on from what time in the morning today?
Yeah, it started about 9:30 in the morning, and it's still, it's still there.
Okay. And if you have to rate it on a scale of 1 to 10 on how severe it is, how would you grade it?
I mean, I would say maybe 8, 9.
Okay.
Yeah.
And so do you have any other past medical history, any in medication you're already on, any previous diagnoses?
Yeah, doctor. So I'm been diabetic for the last 15 years, and I'm taking metformin and a few other tablets. My doctor says, my sugar is always too high, but with the stress and all that, it's really hard to sort of keep things in control, I feel. And he said that I might have to start on insulin also, but I didn't really like that because, with work and all that, it's very difficult. And I've had I think my pressure is high too, and I'm on a tablet for that also.
And when was the last time you got your sugar levels and pressure checked?
That was about uh, 10 months back. It's been
10
some
months
time,
back.
doctor.
Okay. And what else to ask? Any previous surgical histories? Any surgeries in the past?
I've had my appendix removed. That was when I was a kid. Yeah. Other than that, I mean, I've been all right.
Okay. And any allergies?
Not that I know of.
And what about did any of your family, your mother, father, did anyone have any heart conditions, any blood sugar problems, hypertension problems?
Yeah, doctor, my whole family has these issues. Both my parents had diabetes. They've had heart attacks. My brother also recently had a heart attack. My elder brother. So I'm really worried.
And what about any alcohol usage, smoking, or anything else?
Once when I meet my friends, I have a few drinks, and I smoke occasionally also. Yes.
And diet-wise, exercise-wise?
I mean, I go on a lot of site visits, so it's mainly food from restaurants and from outside. I do work a bit on my job, but I don't really exercise when I get back home.
And any changes with your urine or stool?
Uh, Not really. Not that I've noted.
And sleep and appetite has also been fine.
Uh, yeah, I mean, sleep. So I usually stay up late, planning stuff. Appetite has been all right. But yeah, I don't sleep as much as I want to. Yes.
Oh, what else do I take? History.
You have. You have 4 more minutes.
Okay. So do I go for like a management plan, sir, or like?
Yeah, if you feel like you've taken a full history, that's you can do that.
Okay, so I think I would advise for an urgent ECG, and then
Okay.
depending on the ECG changes, maybe go from there if there is any ST
What
elevations.
do you think I'm having, doctor?
Uh, we'll know for sure once we do the ECG, so it's better to eliminate any MI or anything, so we can get
What
go
what
ahead.
what is that? I didn't really
A heart
understand.
attack, a heart attack.
Oh, okay.
We can eliminate any of that. Make sure it's we are okay in that, and then we can send some blood work as well. And then depending on the ECG results, we can go along a management plan from there.
So can I give the blood and go back home and then maybe come back later to check the report?
No, I think it's better we first do the ECG and then give the blood work. And according to the ECG, depending on what the ECG says, we can, I think,
Okay,
proceed
so
from there.
you want me to get admitted or can this be done sort of
I
can
think,
I sort of yeah?
maybe I'm not sure, sir, how the system here works, but ETU maybe.
Okay, so you think that I need to get admitted, eh?
Yeah.
Okay, fine. So if this is a heart attack, doctor, what are you going to do about it?
So since you mentioned that it has started just today morning, so I'm assuming it's been just a few hours, maybe.
Okay.
And then if we are in a place that does offer, if we are in a tertiary care center, I mean, like it's dependent, maybe PCI or
What
somewhere
is
like.
that? I don't really understand that.
Okay, so in layman terms, right? So if this is a heart attack, we can first see if there are ECG changes, and
Okay.
depending on that ECG changes, we can go in for a small procedure that will open up the block in your heart, and that will be good for you long term as well. And since you came quite fast, we can go ahead with that. But if that's not the case, we will put you on, if it's not a heart attack and if it's just a case of chest pain that is preceding heart attack, it's called angina, then we can put you on a medication regimen, and we can help with some lifestyle modification advice as well, so that it won't proceed to anything that is serious.
Okay. So is heart attack the only thing you're thinking, sort of considering, doctor? Is there anything else that this might be?
If
I was just thinking whether this gastritis, I don't eat properly. I eat a lot of spicy food.
Yeah, it could be. It could be. So our immediate concern right now is to eliminate like the most emergency thing. So if it's not that, there are multiple other things. It can be like, it could be even like costochondritis. It can be gastritis. There is multiple other things. So if your ECG and if your blood workup is normal, then we can go about eliminating those options as well and treat accordingly.
Okay, anything that you want me to sort of do later? I mean, like things that you want me to change about my way, about my lifestyle and all that?
Definitely, I would advise you to stop smoking and maybe stop drinking as well, and have a healthy lifestyle and eat healthy food and have adequate exercise.
Okay, okay, thank you. So I'll get myself admitted and then we'll see. All right. Okay. So Nipuni, yeah, good, right? So you're confident, clear. So the way you approached all that was good, right? So just a few things, right, before I discuss step by step. So one very, very important thing that I want to emphasize is so you're having this conversation with a patient, right? So always keep that in mind. I mean, it's obviously difficult right now because I'm not a patient, right? So at the exam, it's going to be slightly easier because it's going to be a real patient. Sometimes they might even give actors, right? If it's just going to be a history, a actor like can always tell this history, right? So you have to be very careful when you about the terms that you use, right? So do not use medical terms, right? So when you in an observed history taking, you would lose marks for using medical terms, right? So always keep that at the back of your head, and every time you feel like saying a medical word, think how you would tell this to your parents or to a friend who is not in the medical sector, right? And always use non-medical terms. Okay. And the other thing is, what usually happens is when you start taking history, you sort of, at the back of your mind, you sort of come to a diagnosis, right? Because most of the time, it's not going to be a very complex case, right? This is of course a very simple case. It might be a bit more complex than this, but usually it's direct stuff, right? It can be an acute coronary syndrome, pneumonia, inflammatory bowel disease. So coming to a diagnosis might not be that difficult. But the important thing about the history taking is the fact that you evaluate it properly and think of all the possible differentials, right? So what you need to think is the examiner is going to assess you and look at you to see, once you become a house officer, what sort of a history you will take and present to him the next day, right? So this is all going to be consultants who's going to come to exam, right? So the thing that's going to be at the back of their head is, if I take this person as a house officer to my ward, is this person going to give a good enough history, right? So what is needed from a house officer is to evaluate every part of the history, to ask everything, because a consultant is not going to go and be like, have you traveled somewhere before? Have you had any high risk sexual behaviors? He's not going to ask any of that, right? So he's going to ask that from you, right? So as a house officer, you should be able to take a broad history, right? And that is what is going to be tested at the exam. So one important thing is you have to consider all the differentials of chest pain, right? This looks like a textbook case of acute coronary syndrome, but you have to always rule out dissection. You have to rule out a pneumonia. You have to rule out a GORD. You have to rule out chest trauma. So that is what is expected, not for you to. So remember, like a mistake a lot of people make is in the history taking, they think you're going to pass if you come to a diagnosis, right? So that is just one of the things for you to pass. The other important thing is that you talk broadly and that you evaluate broadly. And the most important thing is that you cover every part of history taking, right? Right. So there are various components of history taking, right? So for each component, you're going to get a mark. The moment you ask patient particulars, they're going to tick you there. Moment you ask the presenting complaint, you're going to get a tick there. Moment you ask travel history, tick. Drug history, tick. So for every part of the history that you don't ask, you're going to lose marks, which is going to be in vain, because those are easy marks, right? Because history format, you can always memorize and go, right? And if you ask every component of the history, you're going to get some free marks there, right? So those free marks don't miss, all right? So those are some of the important things that you have to keep in mind, all right? So with that in mind, let's just go through, I'm sure you're familiar with this, but let's just go through the history taking steps, right? Sorry. Yeah, slides are moving, right? Right? Slides are moving on.
Yes,
Yeah.
sir.
Okay. So so like Nipuni very well started, you have to always introduce, right? So you have to start by taking the patient particulars. But even before you take the patient particulars, you can always introduce yourself, right? Just like Nipuni did. So I'm the house officer or whatever. At the exam, you can even be like, I have come for the exam. You can even be like, I'm a medical student who has come for the exam, right? I know that all of you have graduated, but it's sort of you're sort of be marked at the level of a final MBBS student. So you can be like, I'm a medical officer who has come for the exam. Can I ask you a few questions, right? And you can always start by asking, are you comfortable to have this conversation in English, right? So that is also sort of a question that you can always ask. Like in any scenario, any station where you are talking to the patient, it can be history taking, it can be communication. Always ask what language they're comfortable in. And just you can ask, are you comfortable with this setting? Do you need someone to accompany you? Right? Don't spend a lot of time there. Just 5 seconds, ask those questions. All right. And then it's important to build a rapport. So that was good. So Nipuni didn't start by asking, why did you come here? Right? She asked my name. She asked my age. Obviously, you know what the sex is. You don't need to ask that. You can ask where you're from, where the patient is from, right? So you don't have to ask the address per se, but you can just ask where they're from. Occupation, day of admission, if it is an in-ward patient, right? If you feel like this is a patient who's come from the ward, you can always ask the day of admission, right? So that is the initial patient particulars, right? Then the chief complaints, right? Now, when you get a chief complaint, you have to ask what is the symptom that brought the patient to the hospital. And the moment the patient says some symptoms, ask the duration then and there. Chest pain, how many days or how many hours, right? Now here it was easy because there was only one chief complaint, right? But usually you can have 2 or more. For example, the patient can have fever for 1 week, followed by cough for 3 days, followed by chest pain for 1 day, right? So it's important to elicit the duration, because you have to always list your chief complaints in the chronological order, so in the order that they occur. Patient is not going to give you history in chronological order, right? Patient is going to tell whatever comes to his mind. So he might be like, I came with chest pain. Then when you ask, he's like, I had fever for 1 week. Then when you ask, he's like, I had cough for 3 days, right? But then you should, in your head, you should sort it out. So fever for 1 week, cough for 3 days, chest pain for 1 day, right? So that should be the chronological order. And then you're going to go on asking about each of the chief complaints, right? So for example, fever, cough, chest pain, you're going to ask about fever, then you're going to ask about cough, then you're going to ask about chest pain, right? Usually, since these stations are 10 minutes, I don't think that they're going to give you very complex cases, right? So it's going to be 1 or 2 chief complaints, right? But don't think it's just going to be 1, right? Then the important thing that you start with is you describe the symptoms nicely, right? So when you get a chest pain, in surgery, you might have heard of Socrates, right? So for any pain, you have something called Socrates. So that is the site, right? I think Nipuni did a very good job there. She asked about all this, right? The site, the onset, whether it came off suddenly, right? And always ask open-ended questions at the start of the history, right? So you can be like, can you describe the chest pain for me, right? Can you just tell me in your words what happened, and let the patient talk a bit, right? At the start. If you let the patient talk for the entire 10 minutes, you won't be able to get a history, right? So you have to ask some close questions like you did. But I felt that you were asking a bit too many close questions, like you were leading me on. So what was the pain like? Was it constricting? Was it stabbing? No. So can you describe the pain for me? Now, let's say he's like, he doesn't really know how to describe it. Then you can, okay. So do you think it was like a stabbing pain? Do you think it was like a constrictive? But at the start itself, if you're like, is it constrictive? Is it stabbing? That means you're asking close questions. You're leading the patient, right? So don't do that at the start of the history. At the start, it has to be always open-ended questions, right? Let the patient talk. You have to ask very short questions. Describe the pain for me. When did it happen? Could you tell me more about it, right? Because again, this is important, because again, if you want to score high marks, they will give more marks for candidates who ask open questions, right? So even in PLAB, even in MR, CPN exams like that, if you ask close-ended questions, you start losing marks, right? Okay. So you should have a nice mix of open-ended and close-ended. At the start of the thing, it's going to be more of open-ended, and by the end of the history, it's going to be more of close questions. No? Fine. Then the onset, then the character, right? So characters can be constricting. That is important, because we know MI, myocardial infarction, is sort of a constrictive pain. You talk about pneumonia causing chest pain or pericarditis causing chest pain, it's more of a pricking type of pain. All right. If it is GORD or gastroesophageal reflux disease, gastritis, that is more of a burning type of pain. So that is why the character is important. So all of these steps are important, because it helps us to differentiate between your differential diagnosis. All right. Radiation is important. So radiation, sometimes the patient might not understand. You can describe it. So was the pain only at the point you described, or did it go somewhere else, right? Then they'll understand, right? Use very, very simple terms. All right. Associated symptoms is very important, right? So that is something that you missed, which is quite important, because when we talk about myocardial infarction, angina, we always talk about a lot of associated symptoms, because the chest pain can be associated with nausea, vomiting, sweating, right? So those are common associated symptoms, right? If it is due to pneumonia, it might be associated with fever and cough, no? So likewise, you have to ask about the associated symptoms, right? So again, you can start with open-ended questions like, other than the chest pain, Mr. Pereira, did you notice anything else? So that's the question you ask. Let's say he's like he's thinking, then okay, for example, did you have some fever, right? Did you have a cough? Then you can start asking closed-end. Got it? So that is how you should always word your questions. Okay. Then the timing. So when did it really occur? So like, for example, did it occur on rest? Did it occur on exertion? That is very important for a chest pain, particularly when you are thinking of an MI, right? Because we know acute coronary syndrome, the pain will persist on rest, while chronic coronary syndrome, it's only on exertion. Then whether it changes with position, like Nipuni asked, right? So that is very important, because pleuritic type of chest pains, pericarditis, they usually get worse with movement, right? When the patient gets up, when the patient moves. So usually when the patient gets up and leans forward, pain might even relieve in pericarditis. But when they're sort of leaning back or when they're lying down, it gets worse. So what are the things that make it worse? Those are called the exacerbating factors, right? So for example, exercise, climbing the stairs, or emotional stress, does that make it worse? And then of course the severity, right? So when it comes to a pain, severity is very important, and like Nipuni very correctly asked, you have to always score the pain on the pain scale. So on a score of 1 to 10, so you can describe it on a scale of 1 to 10, where one is the sort of the most mildest pain you would have experienced, and 10 is the most severe pain that you could imagine. What sort of a pain did you get, right? So that is a question that you can ask. So how you describe the symptom is going to depend on the symptom, right? So for a chest pain, you're going to ask all this. For a shortness of breath, you're not going to ask about the site of the shortness of breath. So for a shortness of breath, it's going to be different. Was the shortness of breath? What was the onset? Did it happen suddenly? Did it happen gradually? Was it progressive in nature? What was the severity? So you have to classify the shortness of breath on the MMRC scale, right? Was there any diurnal variation of symptoms? Is the shortness of breath more in the morning? Is it more in the evening, right? So does it change with the season? Does it change on exposure to dust and all that, right? What are the associated symptoms? Is your shortness of breath associated with cough, right? So that sort of just the shortness of breath change with position. So you want to exclude whether there's orthopnea, paroxysmal nocturnal dyspnea, right? So in shortness of breath, you have a set of things that you ask. When it comes to edema, where is the edema? What was the onset of the edema? Is it both legs? Is it one leg? In the legs, up to what level? Is it more in the morning, more in the evening? Because if it's more in the morning, we know it's more towards renal. If it's more in the evening, we know it's more towards cardiac. What were the associated symptoms? Was there any associated frothy urine? Was there any associated yellowish discoloration of the eyes? So always, depending on the chief complaint, there's always a set of symptoms that you have to, the way you describe. So for pain, it's going to be this set, right? Then the other thing is you have to establish the important negative history, right? So that is something that you have to do, right? So now this happens when you get an easy case. What happens is, this is the diagnosis, right? But remember, it's not about coming to the diagnosis, right? It's about excluding everything else. So although this seemed like a very textbook case of acute coronary syndrome, you have to exclude everything else. Was this a pericarditis, right? So you have to ask whether the patient had a pleuritic nature, whether it got worse with breathing, worse with position, and whether the patient had any risk factors for pericarditis, right? So whether the patient had a recent viral infection or a recent viral infection, right? So that sort of thing you have to always ask. Then can this be a pneumonia, right? So patient, even pneumonias can present with chest pain, right? So whether the patient had any fever or cough, right? Whether this was a case of myocarditis, right? So myocarditis commonly occurs, it can occur due to many, many different causes, but a common cause of myocarditis is a recent viral infection. So you have to ask this patient, Mr. Pereira, did you have any fever in the last few weeks? Did you have any cough in the last few weeks, right? This can be a pulmonary embolism. Pulmonary embolism, yes, the classical presentation is acute onset shortness of breath, but pulmonary embolism can cause chest pain, doesn't it? Right? It's a well-recognized symptom. So did the patient have any shortness of breath? Was there any unilateral leg swelling suggestive of a DVT? Whether the patient had any hemoptysis? Or whether this was just gastritis? So did he have any regurgitation? Oh, very commonly musculoskeletal sort of a pain, like costochondritis. That's something that you considered as well, right? So you have to again ask about heavy lifting or anything that would have caused a musculoskeletal sort of a chest pain. Got it? So the important thing is differential diagnosis, right? So by the time you describe the symptom, you should have some differential diagnosis in your head, right? So what you do today is for each symptom, you think of the differential diagnosis. For the exam, if you get a chest pain, what are the DDs I'm going to think of? Right now for chest pain, these are the differential diagnoses. Likewise, for a patient with shortness of breath, what are the differential diagnoses that you're going to think of? Got it? So like that, you need to make a list. Okay. Then what are you going to ask? You're going to try and find the etiology. So now you have come to the diagnosis that this is acute coronary syndrome, right? Okay. But why did this patient get acute coronary syndrome? Right? So then you need to find the etiology. Okay. So you need to ask about the diabetes. So you took a reasonable diabetic history. So when you ask about diabetes, it's important to ask about the control, right? So that is something that you establish. Hypertension, again, ask about the control. Dyslipidemia, whether there was any smoking, whether there's alcohol. So nowadays, it's not enough to really stop at alcohol and smoking, right? You have to ask about other drugs as well. So things like cannabis are very commonly used nowadays, right? So those also you have to ask, right? And of course, you can be a bit sensitive when you ask these things. I'm going to ask. That's all right, Mr. Pereira. This is for me to come to a diagnosis. Do you smoke? Do you take alcohol? Like that you can ask, right? So if you feel that this is a question that might offend the patient, right? Patient feel uncomfortable, always tell that. Explain to him why you're asking. So those are the things that are going to get you more marks, right? Right? Hello?
Yes,
Can you
sir.
hear me? Okay. So those are the things that will get you more marks, right? So you have to ask about yeah. So you have to ask about you have to make the patient feel comfortable, right? And of course, family history. So that you did a very good job there. So family history is important. So something like family history, if you had missed, right? And if it was possible, now, for example, in this patient, he had a very strong family history, no? So if you had missed that part of the history, you would have lost a lot of marks. Got it? So try to find the etiology, right? So if it was shortness of breath, try to find now, and you think that it's a, let's say you think that it is a interstitial lung disease, you need to find out why this patient got interstitial lung disease. Let's say you're talking about a diarrhea, and you need to find out why the patient got a diarrhea. So you have to always find the etiology. Then the next thing is the complication. So again, so keep this format in your mind, right? So first patient particulars, describe the symptoms, negative history, etiology, next is complications, right? So complications, for example, when a patient comes with MI, patient can go into shock. So you need to ask the patient whether he's feeling dizzy, whether he had any syncope, where he lost conscious. Very commonly, you can get arrhythmias, where the rhythm of your heart goes like sort of haywire, right? So then you should ask whether the patient had any palpitations, right? Right? Because following MI, you can get arrhythmias, right? So you have to ask about palpitations. Following MI, you can get some embolic phenomena. So basically what happens is once you get a MI, you can start developing clots inside your heart. And these clots can sort of embolize to other parts of your body. For example, it can embolize to your brain and you can get a stroke. So you can ask, did you notice any weakness in one side of your body? Right? Don't go and ask, did you get a stroke? Right? You have to always keep things simple. Did you notice a weakness in one half of your body? Sometimes the embolus can go to your leg, right? And you can get sort of limb ischemia. So did you get a very sharp pain on your toes or your legs, right? That sort of thing you have to ask. Then if the MI sort of occurred like a few days back or a few weeks back, you can even get post-MI pericarditis or restless syndrome, right? That is basically, just to keep things simple, it's basically inflammation of the pleura following an MI, right? So you should ask for whether the patient is having a pleuritic type of chest pain now, right? And you need to also ask about the current status. So what has been done up till now? So Mr. Pereira, since coming to the hospital, what was done? So most probably he might have been given some stat doses or something for the pain. Then he'll tell you some medication was taken. Then ECG was taken. They took my blood, something like that. They would have said, right? So don't assume that nothing was done, right? So you should ask what has been done up till now. Now again, this is a very tricky area because some students, right? So what I've noticed is some people spend a lot of time here, right? Dr. මොනාද කිව්වට තියෙන්නේ කියලා? What did they tell you? They did the ECG. What did they tell you after the ECG? Now, don't do that, right? So that is you trying to get the diagnosis from the patient, right? So that will make a very bad impression in the exam, right? Particularly since this is an observed history taking, right? So if this was not observed history taking, you might sort of try to learn something from the patient. But in observed history taking, you can't do that. So don't try to get the diagnosis from the patient, right? You are supposed to come to the diagnosis. So don't ask what was the diagnosis, what did they tell you? Don't ask questions like that. All you need to ask is what were the tests that was done and was any treatment done? That's enough, right? So you don't have to spend a lot of time there. So up till now, what we discussed is the bulk of the history, right? So most of your marks that you're going to get is going to be from this part, right? So that is from the history of presenting illness. For you to describe the symptoms, for you to take a good negative history, to find the etiology, exclude the complications, and to assess the current state. So you have to spend a lot of time there, right? All right. The next most important one is the past medical history, right? So again, at your level, past medical history is something that is very important. The reason is that consultant would want to get that from you, right? He's not going to spend a lot of time with the patient trying to ask the past medical history. So he will expect the house officer to tell that to him, right? So particularly when you have something like diabetes and hypertension, you have to spend some time on it, right? So, so in this patient also, you could have spent a bit more time with the diabetes, right? So let's say the patient says that he has diabetes, then you have to ask him, for how long have you been having diabetes, right? How was it diagnosed? So was this like this could even be a type 1 diabetes that Mr. Pereira had since he was a child, right? Or was this sort of a type 2 diabetes that he developed as an adult, right? So try to establish the type of diabetes. When was it diagnosed, right? And how was the control? So how do you ask about control? One is you can ask him, so have you been checking your sugars frequently? How was it? You can even ask, was an HbA1c done? Patients who are diabetic will know what an HbA1c is, right? Patient who's not diabetic might not know, but a diabetic will know. So that is fine, right? What sort of medication are you on? They might not tell you the names, but at least they'll tell you whether it's a tablet or whether it's insulin. Right? So at least that you can get from them. If they say insulin, then again, you have to ask a few more questions. What is the dose of insulin? Who's administering the insulin? Where are you administering the insulin? Is it to the same site every day, right? Where are you getting the insulin from? How are you storing the insulin? So there are a lot of questions to ask about insulin. Then you have to ask about the complications, right? So in this patient, you have to ask, now he said that he has diabetes for 15 years now. So you have to ask about the complications. Complications can be microvascular complications like retinopathy, neuropathy, nephropathy, right? So you have to ask whether there's any change in the vision, whether he has had an eye test done, whether he's having any frothy urine, whether there's any numbness in his legs, right? Then those are the microvascular complications. Then also ask about the macrovascular complications, right? So macrovascular complications, you have to ask about whether he had any strokes, heart attacks, any limb ischemia features, any acute pain in the legs, those things, right? Then you have to ask about things like recurrent infections. Do you get sick all the time? Do you sort of have any features suggestive of fungal infections, right? And of course, any autonomic complications, right? So do you get dizzy when you get up from the sitting position, right? So that is due to autonomic neuropathy causing postural dizziness, right? Erectile dysfunction, are you having problems with your sexual life? So those things, all that you have to ask, right? So the diabetic history is a major component of the history, right? So if a patient if you're in the observed history taking, if the patient has diabetes, you have to spend a significant amount of time there, right? It's as important as your history of presenting illness. Got it? Things like dyslipidemia, you can quickly run through, right? But diabetes is something that you have to spend time, right? So you have to ask about the control, medication, onset, complications, right? All that needs to be asked. Got it? All right. So likewise for the other things like hypertension, dyslipidemia, also you ask, but not as much as you would ask for diabetes, right? Okay. Then past surgical history. So past surgical history, what's important from a medicine point of view is what was the surgery done, when was it done, and was it done under GA or local, right? So that is basically what we need to ask. The next one is allergic history. So allergic history is also important, right? So if you miss an allergic history in the observed history taken, they can even fail you, right? Because as an house officer, if you miss an allergy, you can even lose your license if you don't manage an allergy properly, right? So allergic is something that you have to take very, very seriously, right? So when you take allergic history also, you have to ask that in detail. Have you had any allergies for any medicine, for plasters, for food? So all those three you should usually ask, right? Food, plaster, and medication, right? So that is important, right? All right. So when it comes to a female, we also have to ask about the menstrual history and obstetric history, right? So you have to memorize this history taking there and just keep ticking these off on your head when you take the history, right? But that doesn't mean for the male patient you go and ask this, right? So only for the females you're going to ask this, right? So menstrual history and obstetric history. So menstrual history from a medicine point of view, now you're not going to take a menstrual and obstetric history like you would do for gyn and obs, right? Very, very short one, right? So what you need to know is whether her periods are regular or not, and whether there's any menorrhagia or not, right? That is what is important to us, right? Whether there's any heavy bleeding and whether it's regular. Obstetric history, what's important to ask is how many deliveries the patient has had. Any complications you can just ask. Things like gestational diabetes mellitus, hypertension in pregnancy can be important. Something that's important from a medicine point of view is recurrent miscarriages, right? So as a practice, ask about recurrent miscarriages also, right? Sexual history is very important, right? So again, you have to ask about sexual history, right? So you might think that in this patient's case, it was not very relevant. But you can never say, right? This patient is having diabetes for 15 years, right? And he might be having erectile dysfunction. He got stressed because of that and got a heart attack, right? So, so things like that also can happen, right? So, I'm just joking, right? But the important thing is you have to cover every component, right? So you have to cover every component because there's some way you can relate it to your case, right? There's some way or the other you can always relate it, right? So strict examiner might mark you down for not asking, right? So in this patient, you ask long-standing diabetes, right? Again, if you feel that it's going to make the patient uncomfortable, tell that this is to come to a diagnosis, right? And I'm asking something personal. Then family history is important. So when you ask about family history, you have to ask for family history of similar illnesses, right? Right? And family history of chronic illnesses that you did, like Nipuni asked about diabetes, hypertension, and also whether there's any heart attacks in any of the family members, right? Okay. Then travel history. So travel history is important, right? So you might feel that it's not very relevant for this case, but it's always good to ask, right? It's always good to ask. For example, this patient might have just returned from Australia and had got a pulmonary embolism, right? You can never say, right? So there's always a way to relate every component of history. So ask about the travel. These don't take a second, right? Have you had any recent travels? Right? It takes only 2 seconds to ask, and that's a free mark for you, right? So don't miss those free marks. Dietary history is very important, right? So particularly in the patient like this, you have to ask about unhealthy eating patterns, right? So whether he eats from outside, whether there's a lot of oil, a lot of fat and all that, you have to ask, right? Personal history is also important. So sleep is important, right? Sleep is important, particularly when it comes to MI. Smoking. So the moment a person says smoking, quantify the smoking, right? So this is again expected at your level, right? So how many cigarettes do you smoke a day? For how long, right? Because you are expected to quantify, right? When they say alcohol, again, you have to quantify. You don't have to, at a 10-minute discussion, you won't be expected to sort of quantify exactly the number of units, but at least whether he's a heavy drinker, he's a light drinker, at least a idea you should be able to gauge, right? So smoking alcohol, the moment the patient says that, you have to try and quantify. Again, if you feel the patient is feeling uncomfortable, always alert the patient before you ask about these things. Social history is also important, right? Social history, how much he has been educated, what is his job like, is there any stress from work? So all that is important, right? So these are sort of questions you ask just to tick, right? Just for you to cover the components. You're not going to spend 5 minutes of this 10 minutes asking about his social history, right? Don't do that. Just a few seconds to cover it, right? Because if there's something significant there and you pick it up, that's going to make a very good impression. Now, this patient is saying that he's very stressed from work, right? So the fact that you identified that is going to make a very good impression at the exam, right? So again, you should be able to ask how this has impacted his disease, how it has impacted his work, how it has impacted his mental health, how it has impacted his normal life, right? Home environment also is important, right? So whether he has to climb a lot of stairs to go up, right? So for a patient with MI, the number of stairs that the patient has to climb is important, right? What sort of a toilet he uses, whether it's a commode or a squatting pan, might be important for such a patient, right? So a few questions about the home environment. Nearest hospital is again very important, right? That is important for us to arrange a follow-up, right? As well as it's important for us to know where to refer him, right? And then you can finally conclude with ICE, that is insight, concerns, and expectations, right? So you have to see what the patient feels about the illness, what are his concerns, and what are his expectations, right? So, Nipuni, you did a very good job. So just make sure that you cover all these components, right? And then you can score more marks, right? So things that you could have scored more was if you had excluded other differentials, right? If you had excluded other differentials and if you had covered the other components, you would have got even more marks, particularly if you took more time on the diabetic history, right? But your confidence, your rate of speaking and all that is good. You can even speak a bit more faster, right? Yeah. And then, so I have the feeling that they might expect you to counsel the patient as well, right? So there, what you need to do is, first of all, you ask the patient, right? So after you take a history, what are your concerns? That's very important, right? Now, for this patient, now you are worried about acute coronary syndrome, but his main concern might be that he has left his child in the school and there's no one to pick him up, right? So until So patient's concern might be different to your concern. Your concern is to rule out an MI, to take the ECG and drop it. But his concern might be different. So you have to recognize what the patient's concerns is. And you have to reassure the patient if his concerns, right? And then when you describe, when you sort of counsel the patient, keep it simple. So Mr. Pereira, after listening to your story, what I feel is that you might be having a heart attack. Mr. Pereira, it can be something else like gastritis or sort of a pain coming from your muscles. It could be something like that also, but what I'm quite concerned at the moment that it can be a heart attack. Don't worry. So what I'm going to do is I'm going to admit you. Now here there's no other option, right? You have to admit this patient, right? Okay. So the questions like that, you have to decide whether to admit or not, right? So I'm going to admit you, Mr. Pereira, and we are going to run a few tests. We are going to do an ECG. We are going to do a few blood tests. And from there, we'll decide what to do. So I'm going to see you in a few minutes after the ECG is done, and we can discuss further. So simple, right? Simple. No medical terms. No medical terms. That is all what Mr. Pereira wants to hear, right? He doesn't want to hear anything else, right? He wants to know whether he wants to get admitted, what is going to happen to him, right? Also, as soon as you finish saying that, the next thing you are going to ask is, Mr. Pereira, do you have any concerns? Is everything clear to you? Right? So every time you give a patient advice, right? So remember, these patients, they have not gone to medical college, right? So what we say might not make sense to them, right? What you say makes a lot of sense to me, but what you say might not make sense to Mr. Pereira, right? So you have to always ask, Mr. Pereira, did you understand what I said, right? Is something not clear to you, right? Is there anything that you want me to repeat, right? Is there any other issues you want me to talk about, right? So always do that, right? Always do that. Because again, in exams like MRCP PACES, you will get a very huge chunk of marks for addressing the patient's concerns, right? And you cannot address the patient's concerns if you don't know them, right? So the main thing is you have to ask the patient's concerns, right? So Mr. Pereira, what are your concerns? What are the questions you have? What is troubling you? There are different ways to word it. Whatever is comfortable for you can use, but make sure. So I forgot to put this in red. Concern should be in red. It should be in bold. It's a very, very important thing, right? So do not miss the concerns. And the moment the patient tells a concern, don't forget to address it, right? So, and he says something like he's scared that this is a cancer or something. You feel like that's a stupid question, and you are like, you forget about that. No, right? If a patient has a concern, you have to address it, right? Then you have to be like, no, Mr. Pereira, it's very, very unlikely that this is a cancer, right? So you can't ask a concern and just forget about it, right? That is sort of rude, right? So that is about observe history taking, right? So that's very important, right? It's very important. It's something that you need to practice. It's something that you can keep practicing with your friends, right? Find someone, tell a history, right? Then do it the other way around, right? Very easy. It's just going to take you 10 minutes, right? And just have a quick chat about what are the things you missed. So the person who's giving the history, keep this format in front and keep ticking what your friend is asking, and tell the friend these are things you missed, right? So you do about 2-3 things like histories like that a day, it's going to be a piece of cake, right? And of course, try to go to the hospitals and take history from real patients, right? Because that's a huge difference, right? Taking history from me and taking history from a patient, you will see the difference, right? It's not going to be this smooth, right? Taking a history from a patient is a challenge. It's an art, right? It's not something that I can teach you over Zoom, right? It takes practice, right? It takes practice. You need to talk to real patients. You need to build that up, right? If someone says that they can teach you all this over Zoom, they're lying, right? So that won't work, right? We can always guide you over Zoom. We can always guide you, but it's your effort, right? It's your effort. You have to make an effort. You have to talk to real patients, all right? Okay, so any questions with regards to history taking? All good? All right. So keep this format in your head and just keep using the format, all right? Okay, so let's move on to examination, right? So probably what they're going to do is they'll give you sort of a they give you a real patient, right? And they'll ask you to examine and present the findings, right? So I can't really do that over Zoom. So what I'm going to do is I'm just going to take some examination findings, and I'm going to tell you what the discussion is going to go like, right? So again, now when it comes to examination, now when it comes to history taking, what I said was the main thing is you have to cover all the components, right? So at this level, for you to pass, the main thing is that you cover the components, right? That is absolutely free marks. Similarly, when it comes to examination, you have to do all the steps, right? Because whether it is a patient with a aortic regurgitation, whether it's a patient with a pericarditis, whether it's a patient with a ASD, whether it's a patient with a VSD, are the steps going to be different? No, right? Whether it's a patient with a pleural effusion, whether it's a patient with a consolidation, are the steps going to be different? No. So there's absolutely no reason why you should lose marks for missing a step. It would be a crime if you lose marks for missing a step, right? So it's not easy as you think it is also. You might be like, Hari, I know CVS, check for this, Pala, this, pulse, pecs, all that. You will memorize and go. But once you go there, it's a different story, right? So you're going to feel stressed and all that. So it has to become a routine, right? It has to become like a sport, right? You know, when you do a sport for the first time, you're always thinking, okay, I have to go and do this. I have to go here and hit the shuttle. I have to go here and pick it up, all that. But after some time, it's reflex, right? The moment you walk into the court, everything just happens, right? So examination has to be like that, right? So it has to, you have to bring it to a level where it's going to be reflex, right? It has to be a spinal level, right? So you should not be thinking and doing examination, right? If someone wakes you up from the sleep and tells you go and do CVS examination, you should go and do CVS examination, right? It should be at that level, right? So that's the main thing. So if you do all the steps, right? If you do all the steps and if you are quite good to the patient, right? You don't cause any pain, right? You're not rude to the patient. You're not handling the patient like he's a sort of a cardboard mannequin or whatever. If you actually treat the patient with respect, right? If you don't cause any pain and if you do all the steps properly, that will give you a very good chance of passing, right? So if you want to pass, you have to do all that, right? And other important things is when you go to the patient, always get the consent, right? Always introduce yourself, right? Always introduce yourself and always get the consent from the patient, right? Always put the blinds, right? So if there's a curtain, there will always be a curtain or a blind. So always put the blinds. Always ask for a chaperone, right? And if there's a sanitizer nearby, always use the sanitizer. So these 4 steps you have to do for every patient, right? Don't be in a rush to go run in and find out whether this is a MR or a AR and forget all that, right? Remember, more than whether it's a MR or AR, what is going to determine whether you pass or not is how you handle the patient, right? So do all these steps properly, right? If you want to undress the patient, like the chest and all that, always get the consent, right? And always ask the chaperone to help. You don't go and lift the shirts and all that, right? Let the chaperone and the patient do it, right? And after you finish examining, again, the moment you finish examining, you are excited. This is a MR. Then you're going to run to the examiner and start presenting. Then straight away fail, right? So as soon as you finish the examination, thank the patient, right? If you have undressed the patient, you have to help the patient dress back. If you have removed the t-shirt, help the patient put the shirt back on, right? So these you might feel like these are small things, these are not important, but trust me, these are the things that are most important when it goes to your examination, right? How you handle the patient. Okay. So what I'm going to do now is I'm going to play a murmur for you, right? I'm going to play a murmur for you, and can you try and tell me what it is? Okay. I hope that you will be able to hear this, right? Right. So I'll get back to the CVS one next, right? So we'll start with the neuro one. So we'll do the neuro one and then come back to CVS, right? Okay. So this is going to be your in neuro you have upper limb examination, you have lower limb examination, you have the cranial nerve, right? So this is going to be one of your cranial nerve examinations, right? So cranial nerves, usually they will say upper cranial nerves or lower cranial nerves, right? So upper cranial nerves are what? 1 to 6, right? Upper cranial nerves would be 1 to 6. So you will be olfactory, usually you don't examine in detail. The optic nerve, oculomotor nerve, trochlear nerve, trigeminal nerve, and the abducens nerve, right? So those are things that will come under upper cranial nerves. When it comes to lower cranial nerve, it will be your what? Your facial nerve, vagus, spinal accessory, and the hypoglossal, right? So So let's say they tell you to examine the upper cranial nerves, right? So in upper cranial nerves, one of the most important steps is the ocular movements. All right. One of the most important steps is the ocular movements, right? So this is the ocular movements of one patient, right? So imagine you go to the test and they tell you to do the upper cranial nerves. And when you're checking the ocular movements, this is what you see, right? So I want you to watch this video. Really hope that you will be able to see this video and tell me what you notice, all right? All right. So can someone describe to me what's going on? So we'll take it step by step, right? Okay. So what do you notice now? So you go to the showcase and this is what you see. What do you notice?
Ptosis.
Yeah. So to be more specific, on the right or on the left? So let's think that this patient is facing us.
On the right side, ptosis.
Yeah. So there's a right side complete ptosis, right? There's a right side complete ptosis. Okay, fine. Then now we are asking. So now we want to check the ocular movements, all right? So now we ask the patient to look to the right. No? We have asked the patient to look to the right. So what we would do is we'll ask the patient to follow the fingers. No? So when the patient is looking to the right, do you see any problem? Nothing. So seems all right. No? Now we are going to ask the patient to look to the left. Do you see any issue? So what do you note here?
There's a problem with the adduction of the right eye.
So there's a problem with the adduction of the right eye. That's what you said, no? So left eye is abducting, right? So left eye is abducting, but the right eye is not adducting. No? Right eye is not adducting. Fine. But is the right eye abducting? Right? Is the right eye abducting? Yes. So right eye is abducting, but the right eye is not adducting, isn't it? Right? Okay. Now, oh, sorry. Then you are asking the patient to look up, right? So what happens when the patient is looking up? Any issue there? Yeah. So even the upward movements are not that great, no? So if you look at the left eye, the upward movement was okay, no? Did you notice that? But in the right eye, the upward movement was not okay, right? Then what happens when you shine a light, sorry, to the left eye? Did you notice anything different between the left eye and the right eye? So I show that part again.
Constriction is there in the left eye.
Constriction is there in the left eye. What about the right eye? Is there constriction?
There's no difference.
There's no difference, no? So what were the things what were the abnormalities? Can someone list me the abnormalities that you noted? So what happens is when you get a short case, now they'll be like, examine the upper cranial nerve. Sometimes they might give you even a focus thing, examine the ocular movements, right? So let's say the command was examine the ocular movements and check the pupillary light reflexes, right? So after you do that, let's say you see this. What are the abnormalities that you've seen?
The right eye loss of adduction, the right eye loss of upward movement,
Okay.
and absent light reflex in the right eye.
Yeah. So to summarize, there is a gross reduction in adduction of the right eye. There's limitation of upward movements of the right eye, and there's a abnormal pupil reflex, right? So pupil reflex is affected as well. So how do you interpret this? So in neurology, neurology is slightly different to other short cases, right? So in neurology, what you have to do is you have to locate the lesion, right? For example, when you get an upper limb, you have to say whether this is an ulnar nerve palsy, whether this is a radial nerve palsy. Then they might ask you what are the causes of ulnar nerve, what is the cause of radial nerve. If when you extend the lower limb, then you might get a spastic paraparesis at the level of T6. Then you know the lesion is at the spinal cord at the level of T6, right? So likewise, if you see this patient, right? If you see this patient, where would you localize the lesion to?
Third cranial nerve also.
On which side?
Right side.
Yeah, so good. So it's a third cranial nerve palsy on the right side. So how do you counter this? So basically, to interpret the ocular movement problems, all you need to know is this diagram, right? So this is a diagram that shows the ocular movements, right? So now let's say this was the patient who was looking at you, right? This was the patient who was looking at you, just imagine, right? So if you, this movement is, can you see my cursor? One second. Yeah. So this movement, now this is the patient's nose, right? This is the patient's nose, right? So when the eye moves towards the nose, what do we call that? Adduction. So this movement is called adduction. This is called adduction. When the eye moves away from the nose, that is called abduction. This is called abduction, right? Then when the eye moves up, that is called elevation. Elevation. When the eye moves down, it's called depression. When the eye rotates this way towards the nose, from this side to this side, that is called internal rotation. When the eye moves away from the nose, rotates away from the nose, that's called external rotation. All right. So for all these movements, there are certain muscles, right? So when we talk about adduction, right? When you talk about adduction, it's mainly medial rectus. When you talk about abduction, it's mainly lateral rectus, right? When we talk about elevation, it's mainly the superior rectus and the inferior oblique, right? When we talk about depression, it's mainly the inferior rectus and the superior oblique. Got it? Internal rotation, external rotation, it's okay even if you don't remember, because clinically to localize where the pathology is, you don't need to worry much about that, right? What you need to know is what adduction is medial rectus, abduction is lateral rectus, elevation is superior rectus and the inferior oblique, and depression is inferior rectus and the superior oblique. Got it? Any questions till now? Okay. Now in this patient, what were the problems? Medial rectus was not functioning properly, no? Medial rectus was not functioning properly. Lateral rectus, that was functioning quite well. No, that was functioning quite well, right? What about superior rectus and inferior oblique? They were not functioning, no, because the eyeball didn't go up, right? Downwards, there was a subtle movement, no? There's a bit of a subtle movement. But you know for sure that lateral rectus is okay. You know for sure that medial rectus is not okay. And you know for sure that the superior rectus and the inferior oblique is not okay. No? Now you need to know which of these muscles are supplied by which cranial, right? So the easy way to remember that is all of the ocular muscles are supplied by the third cranial nerve. Everything except the lateral rectus is supplied by the 6, that is LR6 and SO4. Remember, everything is by the third nerve except for LR6 and SO4. LR6 means the lateral rectus is supplied by the abducens nerve, while the superior oblique is supplied by the trochlear nerve, right? So in this patient, where's the lesion? Medial rectus is gone, inferior oblique is gone, superior rectus is gone. And you can see all these muscles are supplied by the third cranial nerve, right? So he's having a problem with the third cranial nerve, right? He's having a problem with the third cranial nerve. Is his sixth nerve affected? No. Sixth nerve, it causes abduction. His abduction was quite good. So his abduction was quite good because his abducens nerve was functioning. Trochlea is also possibly functioning because his depression was also not that effective, right? But you know for sure that his third nerve was affected. Got it? Right? Any questions? Do you want to see the video again? No, right? So got it, right? So he had a problem with the adduction and the elevation. So you know that this is medial rectus, superior rectus, and inferior oblique. So you have localized it to the third cranial nerve, right? Now the next thing is, right? When you get a third cranial nerve, the next problem is you need to know whether this is sort of a surgical cause of a third cranial nerve or a medical cause of a third cranial, right? So how do you differentiate? So why did we look at the pupillary reflexes? So what is the purpose of finding looking at the pupil reflexes in this patient? Okay, so pupillary reflex, right? So the light reflex, what is the afferent pathway and what is the efferent pathway? What is the nerve that carries the signals to the eye, to the brain, and not really to the brain, to the brainstem where the reflex occurs? And what is the nerve that carries it back to the eye? What is the afferent pathway? What is the efferent pathway?
Current pathway is optic nerve.
Sorry, afferent pathway is the
Optic nerve.
optic nerve. Good.
And the efferent pathway is parasympathetic component of the third nerve.
Yeah, exactly. So third nerve is also involved in the pupillary reflex. So now you know that in his right eye the pupillary reflex was affected, right? So that means there's either a problem in the optic nerve or there's a problem in the third nerve. And since this patient is already having features of a third nerve palsy, you should consider the fact that the absent pupil reflex or the dilated pupil is because of the third nerve palsy, right? So you get the pupillary reflex being affected in a surgical cause of a third nerve or a medical cause of a third nerve.
In the surgical cause?
Yeah, very good. So it's in the surgical cord. So like your friend mentioned, it's the parasympathetic fibers, no? And these fibers are located in the outside of the nerve. Now, if you take a cross section of the nerve, right, the fibers that are sort of carrying the signals for the pupil reflexes are located on the outside. Now, medical causes will sort of affect the inside of the nerve, while a compression will start compressing from outside. So that is why a surgical cause that is compressing will always affect the pupillary reflexes, right? So that is the importance of checking the pupillary reflexes in this patient. Got it? Okay. Any questions there? So the diagnosis here is it's a surgical third nerve palsy, right? So basically, now that term is actually kind of becoming redundant, right? The medical and surgical terms are becoming a bit redundant, but it's important to differentiate because that will help you to come to an etiology, right? So here what you have to say is this is a third nerve palsy with pupillary involvement. So how we discuss is rather than say medical or surgical, we say it's a third nerve involvement with pupillary involvement or without pupillary involvement. So if it's a third nerve palsy with pupillary involvement, what are the etiologies?
Can be due to increased intracranial pressure.
Okay, so typically increased intracranial pressure usually causes a sixth nerve palsy, but depending on the etiology, you can get third nerve palsy also. Yeah, fine. Classically, it's due to something called a posterior communicating artery aneurysm, PCOM aneurysm, right? So surgical third nerve or a third nerve palsy with pupillary involvement is usually due to posterior communicating artery aneurysm, right? What about the medical causes of third nerve palsy?
Diabetes can cause.
Yes, well done. Yeah. So diabetes, right? So diabetes is one of the commonest causes of a medical third nerve palsy. Do you know any other causes?
Syphilis may cause.
Okay. So certain demyelinating diseases like multiple sclerosis can cause, alright? And strokes can also cause, right? So the relevant points that you have to look in the examination is you have to look at the pupils, right? You have to look for other cranial nerve involvement and you have to look for features of stroke also, right? Whether there is hemiparesis and all that, alright? So, so if you get this patient for the exam and you see these findings, they might ask you to present the findings, right? So you can be like, I have examined the upper cranial nerves of this gentleman, where I found that the olfactory nerve examination was normal. In the optic nerve examination, his visual acuity was normal, color vision was normal, accommodation reflexes were normal, but I found a dilated pupil with absent pupil reflex on the right side. The patient had a complete ptosis on the right eye, and on ocular movements, I noted that the patient has limitation of the adduction of his right eye, along with limitation of his elevation of the right eye, while the ocular movements of the left eye was full and free, right? So based on these findings, I believe that the patient is having a third nerve palsy with pupillary involvement, right? So that's how we present, right? Then they'll be like, so why did you think it was a third nerve? Then you have to be like, because the adduction and the elevation of the eye was affected. So I believe that there's weakness in the medial rectus and the superior rectus, which is supplied by the third nerve. So then they might ask you, what are the etiologies? So since the pupillary reflex was affected, since the patient has a dilated pupil, I would consider surgical causes, including posterior communicating artery aneurysms or a space occupying lesion in the brain, right? If the pupil reflex was not affected, I would consider medical causes like diabetes mellitus, demyelinating diseases like multiple sclerosis, and stroke, right? So what investigations would you do for such a patient? What are the investigations you would do?
So brain imaging.
Yeah, so you would consider doing some neuroimaging, right? So something like a CT scan or a MRI, because you want to exclude something like a space occupying lesion. If you really want to exclude a posterior communicating artery aneurysm, you might actually have to go for an angiogram, right? A CT or a MR, angiogram is the one that will pick it up, right? So if this was there was no let's say there was no pupillary involvement, pupils were normal, then what are the investigations you would do?
A nerve conduction study.
Sorry?
Nerve conduction study, maybe.
Yeah, so nerve conduction studies we usually do for the limbs, like upper limb, lower limb. So where let's say you think there's a peripheral neuropathy or a ulnar nerve palsy, radial nerve palsy, then you go and do a nerve conduction study. For the eye movements, nerve conduction study is a bit difficult, right? So what we do is to find the etiology, right? So what we can do is we can do a fasting blood sugar and HbA1c to look for diabetes, right? Then if you're thinking of stroke, again, you might do a CT brain or a MRI brain and brainstem. Look for features of a stroke. If you're thinking demyelinating, again, you can do a MRI to look for the demyelinating lesions, right? Then they might ask you, how do you manage? So the management would depend on the etiology, right? So if it's a posterior communicating artery aneurysm, you might have to clip the aneurysm. If it's diabetes, you just have to control the sugars with medication, right? If it's demyelinated, you would refer to the neurologist to start treatment, right? If it's a stroke, you might start antiplatelets for secondary prophylaxis, like that. So they won't focus much on the management and all that. Main thing is steps. If you miss the steps, you're going to lose a lot of free marks, right? So main thing for examination, do the steps properly. If you do the steps properly, and if you handle the patient well, there's a very high chance that you can get through, right? Okay. So okay, so let me try and play that sound again. Okay. So you can hear sort of a like abnormal sound, right? So you can hear the lub dub, right? You can hear the lub dub, and you can hear an abnormal sound after that, right? So that abnormal sound that you hear is called a murmur, right? What you hear is called a murmur, right? So basically, usually when you get the sound, abnormal sound between those two heart sounds, it's usually a systolic murmur. So way to confirm is you can palpate the carotid pulse, right? So if you hear this abnormal, so when you're palpating the patient's carotid pulse, if you hear this that abnormal murmur along with the pulsation, that's a systolic murmur, right? That's a systolic murmur, all right? If you hear this, not when the pulse is coming, right? So you can always feel the pulse touching your finger. So when the pulse is touching your finger, if you're hearing this murmur, it's a systolic murmur. If you're feeling it otherwise, it's a diastolic murmur. So let's say you heard this murmur when you were auscultating the apex of the heart, right? When you were auscultating the apex of the heart, you heard this murmur and it was not corresponding with the carotid pulse. So it's a diastolic murmur at the apex, right? So what is the usual diastolic murmur that you get at the apex? Do you get systolic murmurs at the apex? Can you name a classical systolic murmur that you get at the apex?
Mitral regurgitation.
Mitral regurgitation. What is the diastolic murmur that you get at the apex?
Mitral stenosis.
Yes. So remember now to keep things very simple, right? Just to keep things very simple, right? Or if you know this chart, right? It's very easy to sort of interpret your CVS findings, right? So for your CVS, the main things that you can get is aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation. Rarely you might be given an ASD or a VSD. That is quite rare, right? Usually it's going to be one of these four, usual, right? So for you to come now, for you to pass, first thing is do all the steps, right? So all the steps of cardiovascular examination you do. To interpret, if you know this if you know this table, you can always interpret, right? So one thing is you should be able to differentiate a systolic murmur and a diastolic murmur, right? So how you do that is listen to that abnormal r sound, right? So that abnormal sound is the murmur, right? See whether it coincides with the carotid pulsation. If it is, then it's a systolic murmur. If it's not coinciding, it's a diastolic murmur, right? Then depending on whether it's a systolic murmur or diastolic murmur, and depending on the site, you should be able to interpret. The other things that that's going to help you is the pulse and the patient's apex, right? Pulse and the patient's apex. So we'll go through how we are going to do this, right? In the case of aortic stenosis, what you're going to hear is a systolic murmur at the aortic area. So you all know what the aortic area is, right? So aortic area is on the right sternal border, right? It's on the right sternal border, right? Aorta is on the left, but the aortic area is on the right sternal border, right? So in the right sternal border, in the second intercostal space, if you hear a systolic murmur, right, that is most likely going to be aortic stenosis, right? Things that are going to help you is that this murmur is going to radiate to the neck. So when you auscultate over the neck, again, you're going to hear the same murmur, right? Then when you look at the pulse, it's going to be a low volume pulse. It's going to be a low volume pulse. When you palpate the apex, apex is going to be undeviated. Undeviated means it's going to be in the fifth intercostal space in the midclavicular line, right? Then it's going to be a heaving apex. Heaving apex is when you palpate the apex, you can feel the apex coming and hitting your hand, right? Tapping apex means if you palpate over the apex, you feel a tap. Someone is tapping, 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 tapping. That is called a tapping apex. Heaving apex is like that. It's coming and touching and going, touching and going, touching and going. Thrusting apex is it's pushing your finger up. So the moment you palpate the apex, someone is pushing your finger up. That is called a thrusting apex. So there are three types of apex characters. What are they? Tapping apex, heaving apex, and the thrusting apex. The apex that pushes your finger up is the thrusting apex. So aortic stenosis, what are we going to get? Systolic murmur at the aortic area. It's going to radiate to your carotid. Your pulse is going to be low volume, and your apex is undeviated and heaving. So if you get this combination of findings, it's aortic stenosis. Got it? Aortic regurgitation, you're going to get a diastolic murmur at the left lower sternal edge, right? Left lower sternal edge, diastolic murmur. Pulse is going to be very high volume, collapsing pulse. So when you in aortic stenosis, when you palpate the pulse, you might not even feel it properly. But aortic regurgitation, you feel a nice, very heavy pulse. And it's called a collapsing pulse. Collapsing pulse is when you hold the patient's hand straight and when you raise it up, you can feel it bounding, right? So all of you have seen that, I believe. Apex, on the other hand, it's going to be displaced. Now, aortic stenosis, it's undeviated. It's in the fifth intercostal space. Aortic regurgitation is displaced. It's pushed downwards and lateral. And it's going to be a thrusting apex. So you get a thrusting displaced apex. What is thrusting? Pushing it up. So high volume pulse, thrusting deviated apex, diastolic murmur at the left lower sternal edge, that is aortic regurgitation. Mitral stenosis, you get a diastolic murmur at the apex. Diastolic murmur at the apex. Pulse is going to be normal or low volume. Sometimes the patient can have an irregular pulse due to atrial fibrillation. Apex is going to be a tapping apex. Tapping apex, undeviated. So remember, your stenosis murmurs are undeviated. Your regurgitation murmurs are deviated apex. Your regurgitation murmurs are thrusting apex. Your stenosis murmurs in aortic stenosis, heaving apex, mitral stenosis, tapping apex. So that's very easy to remember. Actually, if you do the pulse and the apex, if you palpate the pulse and the apex, before keeping the stent itself, you can diagnose the murmur, right? If you properly palpate, right? So mitral stenosis, tapping apex undisplaced, normal pulse, and it's a diastolic murmur at the apex. Mitral regurgitation, systolic murmur at the apex, high volume pulse, or sometimes even a normal pulse. Since it's a regurgitant murmur, displaced apex. So apex is going to get displaced downwards and outwards, and it's going to be a thrusting apex. Got it? So that is all that you need to know, right? Okay. So keep practicing the CVS steps, right? Keep practicing the CVS steps on your patients, right? Even if it's a normal patient who doesn't have any findings, it's fine. Get used to the steps. If your steps become like, it becomes smooth and like a reflex, you will definitely pass, right? Interpretation part, of course, you can figure it out, right? But the main thing is the steps, right? And how you handle the patient, right? Keep listening to murmurs, right? There are enough murmurs on the internet, right? So you can listen to all of these murmurs on the internet on YouTube. Make sure that you train your ear to pick these murmurs. All right. So make sure that you know this chart properly. Know whether it's a systolic murmur, diastolic murmur, where are you hearing the murmur, what is the pulse, what is the apex. Those 5 things, right? From that, you can always interpret. Got it? And then they will ask you a few questions like how you're going to diagnose. So you're going to do a 2D echo to find out what the valvular lesion is, to find out the etiology, and to decide on the management, right? So they might ask you what are the etiologies. So usually things like mitral stenosis are due to rheumatic heart disease. Regurgitant murmurs like mitral regurgitation, aortic regurgitation can be due to infective endocarditis. It can occur secondary to myocardial infarctions. It can be due to connective tissue, collagen diseases like Marfan syndrome, right? Aortic stenosis is usually due to old age. It's due to a degenerative valve and rarely due to congenital valvular defects, right? So questions are going to be simple. Don't worry much about that. Focus on the examination steps. Got it? All right. So another station that you might get, right? So another station that you might get is emergencies, right? So they might give you a situation like an emergency situation, and they might ask you how you're going to approach, right? So anyone wants to sort of try that? Any volunteer? So don't worry, it's just going to be a trial, right? It's just for you to get an idea what sort of questions they will ask and how it will go, right? You don't have to give the right answers, right? Just to get an idea how the questions, like the format, right? How things will go, right? Anyone can volunteer? All of you study for theory, so don't worry, right? It's just going to be very simple questions, right? It's going to be very simple questions, and I'm just going to I just want to get you used to the give you an idea like how it's going to go, right? So any volunteers? Can I call a name? No volunteers? Girindu, would you like to try? Yeah?
Okay.
All right, thank you. So, Girindu, you are the house officer in the ward, right? So you passed ERPM, now you got your appointment and you've gone there. And in the middle of the night, you get a 65-year-old lady, right? She has diabetes, hypertension, and dyslipidemia. And she's telling you that her left arm and leg are weak for the last 3 hours. Step by step, tell me what you're going to do. Yeah, go ahead.
First,
Hello. Yeah.
first I will approach the patient and ask about brief history, not detailed one.
Okay.
And after that, I will do ABCD, I think, because.
Okay. Good. Okay. So you want to check the patient's airway, breathing, and circulation, isn't it?
Yes.
Okay, fine. So how are you going to check the airway?
Airway, first, if the patient is talking and normally talking, airway is okay.
Airway is fine. Yeah, very good. So the patient is talking to you. She's giving a history. So airway is okay. Breathing?
Breathing, I'll auscultate the lungs.
And probably you. Okay, yeah.
And I will ask any difficulty in breathing.
Okay, so lungs are clear and the nurse comes and puts a saturation probe. The saturation is 100%. So breathing also okay. Then
I will check the central and peripheral pulses and
good.
blood pressure also.
Okay, so pulses are okay. Pulse rate is 90 beats per minute. It's regular. Blood pressure is 140/80.
And I'll check auscultate the heart also.
Okay, good. So what you heard hoping to hear?
Any murmurs?
Yeah, good. Because murmurs, because why? Because valvular heart diseases can cause cardioembolic stroke, no?
Yes.
Yeah, very good. Okay, fine. So very competent house officer, right? Very good. So you have checked the airway, breathing, circulation. Now you put the patient out of danger. So this is what we want, right? We want the house officers to be safe, right? So that's what the examiners want, a safe house officer. So this is what a safe house officer would do. So airway, breathing, circulation done. Very good. You have auscultator for murmurs. Okay, fine. Now what do you want to do?
I'll do quick neurological examination. Okay.
Okay, good. So neurological examination, GCS is 15/15. Cranial nerves, there's a upper motor neuron type 7 nerve palsy. Right arm and leg, the power is 2/5. Reflexes are exaggerated. Right side planters are upgoing. Rest of the neurology examination is normal.
I'll check the blood sugar also quick, capillary blood sugar. Also.
Superb. Blood sugar is 120.
And I'll ask the patient how long she is having the symptoms because
Yeah. So she's been having it for 3 hours.
and as a next step we should do, I think, NCCT.
Yeah.
So
Yeah. So you have done a CT, right? This is your CT.
So there's no intracranial hemorrhages. So most probably this is a ischemic stroke. According to neurological deficit, I will calculate NIHSS score. If it is between 5 to 25, and I will take brief history about surgical and recent hemorrhages and recent surgical history and control of diabetes. We got the random blood sugar.
Okay.
According to those parameters, I'll ask senior opinion to go for a TPA.
Go for it.
TPA.
What is TPA?
Thrombolysis.
Thrombolysis. Okay, good. Yeah, very good. Okay, after that?
After that, we'll keep.
Okay, fine. So Giridhar has done an excellent job, almost like a neurology registrar. He has managed this stroke very well, right? He has thrombolized. So now next day the consultant comes and he's very happy with your management. So now the patient is in the ward, right? Patient is in the ward, right? Patient's weakness has sort of improved with the thrombolysis, but there's so bit of a weakness is still there. Power is about 4/5, right? So what are the things that you're going to do for this patient?
We'll control the other parameters, stabilize the patient, the blood pressure and the sugar. And we'll start physiotherapy.
Good.
If there's a speech impairment, we can start speech therapy also.
Yeah. So when you want to discharge this patient, any medication that you want to give him before any medication you want to give her before discharge?
Yes, the patient should on aspirin to prevent further strokes, and we can add statin also.
Okay.
To dyslipidemia, and we can advise the patient about good glycemic control.
Okay. So Girindu has done an excellent management. So next day also, now when a stroke patient comes, now they have referred to Girindu again, right? So this time your patient has a blood pressure of 190/130. What are you going to do?
At this point, we can't go for TPA because of the diastolic blood pressure is 130 and systolic also more than 185. So we'll try to gradually reduce the blood pressure within next 1 hour. If we succeed, we can go for TPA.
Okay, but let's say Now the second patient with the high blood pressure has come after 8 hours. He has got the stroke, watched some TV, had dinner, all that, and come the next day to you, right? After almost 10 hours. Now the BP is 190 by 130. What are you going to do?
Still CT is normal, sir.
Yeah.
If it is normal, we can go to aspirin and clopidogrel 300 milligram.
Okay.
High dose.
Would you reduce the blood pressure?
Yeah, but gradually.
Gradually. Okay, fine. Yeah. So superb. So well done. Very good. So yeah, so that is basically how a sample emergency would go, right? So it's going to go for a bit longer. So what happens is they'll give you a scenario. Mr. X comes with this comes with a chest pain. What are you going to do? Then you'll be like, I'm going to check for the airway. Okay, when you check for the airway, patient is not vocalizing. What would you do next? Then you have to talk about how you would open up the airway. So like that, the examiner will guide you, right? So at every step they will tell you. So every time you say, let's say, I will assess the patient circulation, then they will like blood pressure is 80 by 30. Then you have to say you have to give a fluid bolus. So that's how the emergency goes, right? So step by step, how we are going to approach this patient, right? So the important things about emergency, common to every thing is that you have to assess the patient's airway, breathing, circulation at the start, right? So now in this one, if you start by saying you are going to go for a CT, that's going to be a problem, right? So any emergency, there are some things that you have to say at the start, right? So one thing you have to say is, sir, this is a medical emergency. I would attend to this patient immediately, right? I would attend to this patient immediately. I would manage this patient in an acute or HDU bed, right? You have to say that, right? You're not going to put this patient as the last patient in the last cubicle. You're going to put this patient to acute or HDU cubicle, and you're going to attend to this patient immediately, right? So you have to say that, right? That this is a medical emergency. I would attend to this patient immediately. I would inform my seniors about this patient. That is also something that you have to say, right? And airway, breathing, circulation is something that you have to say for every patient. So the order in which you say that is, first you start by saying it's a medical emergency, that you would put the patient into the acute side bed and HDU, and I would connect the patient, ask the nurses to connect the patient to a multi-para monitor. Then the next thing is, even before calling the seniors, you would be assessing the patient's airway. There's no point trying to call your seniors if the patient's airway is compromised. You have to do something about that first, right? So I would assess the patient's airway. So like Giridu said, you have to talk to the patient. If the patient can talk back to you, probably the airway is all right, right? If the patient can't, then you have to open up the airway. So you might have to go for things like jaw thrust, head tilt maneuvers, chin lift maneuvers, right? Then you assess the patient's breathing. So breathing, you're going to check the patient's saturation, respiratory rate, and do a quick auscultations. If the patient's saturation is low, so for stroke, if the patient's saturation is less than 94, we usually give oxygen, right? So if the patient's, let's say, now I said that the saturation is good, but let's say the examiner says saturation is 88, next step would be to give oxygen. Then you might try with the nasal prongs. If that doesn't work, face mask, that doesn't work, non-invasive ventilation, or if that doesn't work, intubation. Right? Then next is the circulation. So I would be checking the patient's pulse and the blood pressure. If the circulation is compromised, if the patient is in shock, I would obtain IV access with 2 large bore IV cannulas, and I would give a fluid bolus. Right? So that is what you say first. Then after the airway, breathing, circulation, you have to say, I would inform my seniors that a patient like this has arrived. Right? So that is also important, right? So at the level of the house officer, it's also important that you don't try to be too confident and manage everything on your own. You have to get the seniors involved. But also it will be irrational if you call the seniors as the first thing. Soon as the 65-year-old patient comes with a stroke, patient then what are you going to tell him, right? Or he'll be like, right? So there needs to be something that you tell him, right? So first of all, you have to make sure that the patient is stable. So get the patient to acute bed, assess the patient's airway, breathing, circulation. Once that is under control, then you tell the senior, right? Okay. Then the next thing is going to be the definitive management. So that will depend from case to case, right? So for example, if it's a stroke, first of all, assess the airway, breathing, circulation. If the saturation is less than 94, always give oxygen. And Giridu brought out a very good point, right? It's very, very important to measure the sugars in a patient with stroke. Because don't think that every stroke is due to every patient coming with a hemiparesis is having a stroke. hypoglycemia can come with like a stroke. Migraine headaches can come like a stroke. SOS this tumors can come like a stroke, right? It's very important that you exclude hypoglycemia because that is a easily correctable thing. No? And if you don't correct hypoglycemia, you can even get lifelong disabilities, or you can even get death. Patient can even die due to hypoglycemia. So hypoglycemia is a killer that you have to treat at the start. So let's say you miss the hypoglycemia and you send this patient to the CT. By the time, let's say the CVS the sugar was about 40, by the time he comes from the CT, the sugar will be about 20, and he might even die due to the hypoglycemia. So it's very important that at the start itself you exclude the hypoglycemia. So that's very good that you brought that up. In a patient coming with hemiplegia, check the sugar at the start. In fact, when you talk about ABC, it's ABCD. When it comes to the disability, where we usually assess the patient's GCS and the sugar. So especially in a patient coming with hemiplegia, check for the hypoglycemia and correct it. Then if try to get IV access, then monitor the vitals. Then like Gindu said, try to do a focused neurological examination. You can't do everything, but you have to do a focused neurological examination, and then you classify the classify the severity according to the NIHS scale, right? And you need to know when was the time what was the onset of the stroke, right? So if a patient comes with an ischemic stroke within 4.5 hours, we can thrombolize the patient, right? But before thrombolizing, we need to differentiate whether this is an ischemic stroke or a hemorrhagic stroke. So for that, what we do is we do a urgent CT scan or MRI. CT scan is good enough, right? In the CT, we are not looking for features of an ischemic stroke. No. All we are looking for is whether there's bleeding or not. If there's no bleeding, then we can manage as an ischemic stroke. We don't need to see an infarcted area, right? So don't think we are doing a CT to look at the infarcted area. No, we are doing a CT to exclude bleeding, right? So this is what an infarcted area would look like, but we don't have to see this. All we need to, even if you see a normal CT, that is enough to manage as an ischemic stroke, right? So if the patient comes within 4.5 hours, right, we can thrombolize the patient, where we usually use TP or alteplase, right? Another drug that can be used now is tenecteplase. But before thrombolizing the patient, we have to exclude the exclusion criteria. Whether the patient is having any active bleeding, whether the patient has had a ischemic stroke within the last 3 months, whether the patient has had a hemorrhagic stroke at any point of time, whether the patient has had a recent surgery. So after excluding the exclusion criteria, we can give thrombolytic agent, right? Important thing about the blood pressure is before thrombolizing, your blood pressure has to be 185 by 110 or lower, right? You need a blood pressure lower than 185 by 110. Because if you thrombolize a patient with a blood pressure more than that, the patient will get a hemorrhagic stroke, right? Another option that we have is something called endovascular thrombectomy or mechanical thrombectomy. So mechanical thrombectomy, you can actually do up to 24 hours if you have advanced imaging, right? So if you know that there's something called mechanical thrombectomy, that's enough, right? But thrombolysis, you need to know that you can thrombolize patients within 4.5 hours, right? So blood pressure management, if you're thrombolizing, before thrombolysis, you need a blood pressure less than 185 by 110. And after thrombolysis, you have to bring it down to 180 by 105. But if you are not thrombolizing, so that is what I was asking with the second patient, right? If the patient is outside the thrombolysis window, and if you are not thrombolizing these patients, we reduce the blood pressure only if it is more than 220 by 120, right? So anyone knows the reason for this? Why we do not reduce the blood pressure if you are not thrombolizing? So if you are thrombolizing, we are reducing because we want to prevent hemorrhagic stroke, right? But if you are not thrombolizing, we let the patient have a high blood pressure. Why is that?
The blood pressure is the reason why the perfusion is still happening.
Yeah, very good. So when the patient comes with a stroke, there's a penumbra. Penumbra is the area that is still getting perfused. So the high blood pressure will allow that area to be perfused. So we will reduce the blood pressure only if it is more than 220 by 120, right? Then on discharge, we give the patient antithrombotic therapy. If we are not thrombolizing, we can start the antithrombotic therapy with aspirin and clobid immediately. But if we are thrombolizing, then we have to delay it for at least 24 hours after thrombolizing, right? So we don't thrombolize and immediately give aspirin and clobid, right? We give it only after 24 hours. If you are not thrombolizing, we can give it immediately. Patients with minor stroke, we can actually give dual antiplatelets for 21 days. And after that, it's going to be single antiplatelet, right? So then the rest of the management, you're going to monitor the patient, look for complications like DVT, monitor for infections, and like Genitu very correctly said, start physiotherapy, right? Okay, so that is how a emergency is going to go, right? So they'll give you the scenario, step by step, expect you to manage. Remember, put the patient to the acute site bed, A, B, C, D, and make sure that you inform the seniors. All right, so one last station before we finish up, right? So this is another possibility that can they might give, right? Things like communication, right? So communication is also very important, and communication stations are there in almost every international exam, right? So they might include it here as well, right? So communication would include things like for you to give advice to a patient, right? For example, a patient taking warfarin, for you to give advice on how to take warfarin. A very common communication is breaking bad news. Let's say a young patient has got diagnosed with cancer. Break the bad news to the patient, right? One other thing is explain a procedure, because as a house officer, you would have to explain many procedures, right? Consultant will come and say, do a lumbar puncture, do a peritoneal tap, do upper GI endoscopy. But you are the one who has to go and talk to the patient and get the consent, right? Because you know you can't do anything to a patient without their consent, right? So these are some of the skills that will be tested in communication, right? So again, we'll practice one. So don't worry, right? So volunteer, just give it a shot, right? It's going to be good practice for you, and it will give you an idea about how things are going to go, right? Okay, so this is not an exam, this is just for you to practice. Okay, so can someone volunteer for this scenario? So we have Mrs. Pereira. So husband got a MI, now she's coming with a Melina, right? So she's 50 years old, and now she has presented with Melina for 1 week, right? With anemic symptoms. Okay, she has had a history of loss of appetite and significant loss of weight. So hemoglobin is quite low. You have transfused some blood to the patient and stabilized, and your consultant wants to do a upper GI endoscopy in the evening. All right. So you as the house officer are expected to explain the procedure to the patient, get the consent, and answer any questions. Of course, can someone please volunteer? So what you have to do is you have to explain to the patient why she needs upper GI endoscopy, right? Try to get the permission from her for that. And if she asks you any questions, answer those, right? So don't worry, I mean, all of you know what upper GI endoscopy is, right? It's basically when you pass a camera down your throat, right? And try to visualize the inside of your stomach and the small intestines, right? So can someone give it a shot? Any volunteers?
So first, I will ask for consent from the patient regarding.
Yeah. So we are going to do this as a scenario, right? I'm going to be Mrs. Pereira. So think that so you are the patient in front of you, right? So just try to explain the procedure to me and get the consent, right? So start by introducing yourself and we'll go from there. All right. Okay. Start.
Good evening, Mrs. Pereira.
Good
My
evening.
name is Sankar. I'm a final year medical student. So I'm a house officer. I'm sorry, I'm a house officer. So there's a small procedure that we must do. It's called upper GI endoscopy. For this procedure, I need your consent. Would you be okay with giving me your consent?
Yeah. So doctor, could you sort of explain this procedure to me?
So what we're basically doing is we'll be putting a flexible tube from your mouth into your food pipe. So where basically what we'll do is we'll see if there's any problems, and thereby we can diagnose what's wrong and start the treatment accordingly.
Okay. So is this tube, this flexible tube, is it going to be like a very big one? Is it going to hurt me?
So what we'll do is we'll give you some medication for the pain, and the consultant who is doing it, he's very good with this, and he'll make sure that there's no pain with this, and the tube is not that big. It's easily swallowable. It won't be a problem.
Okay. So are you going to like give me anesthesia? Like, am I going to be awake for this? Or
So we'll have to make sure that you're not going to eat anything. So you're going to stay fasted for a certain period of time.
okay.
And we can do this under anesthesia, or but we usually do it with a pain medication, a numbing cream, I would say.
Okay.
And
Okay. Yeah. So I just say fasting for 6 hours. All right. So doctor, are there any complications that I can get from this?
there can be some complications where something can go into your airway, or there
Okay.
can be small tears, and there can be bleeding. So we'll make sure that none of these things will happen. Don't worry.
Okay. So what sort of problems do you think can be found from this, doctor? Like, I mean, I know you explained to me that it's positive and you're going to sort of take photos of my like stomach and all that, right? So what sort of problems might you pick up?
So basically, we'll be able to see if there's any ulcers, if there's any wounds, there's any dilated veins, or any strictures, anything that's blocking the food passage, and or any growths.
Hmm. Okay. Okay. So Doctor, I'm a bit, I'm a bit worried about this. You said that there can be bleeding and tears and all that. I'm a bit frightened, doctor. So
We can go for some imaging options like CT,
uh-huh.
or there's a tablet you can take where there's a camera. You can swallow it.
Okay.
We'll be able to see it. But I think for you in this instant, the best thing we can do is an upper GI endoscopy, as I described earlier.
Okay. Okay. All right. So could you give me a few minutes to do that? Yeah. Okay. Yeah. Can you hear me, Sagar?
Yes, sir.
Yeah.
So it's breaking apart the connection. It's not constant.
Yeah. Sorry. Can you guys hear me now? Sorry about that. I lost my connection. Yeah. So Sang, you can hear me now, right?
Yes, sir.
Yeah. So that's how this communication goes, right? So you'll be given a scenario and you'll be asked to sort of break bad news, so explain a procedure, get consent, that sort of a thing, give advice, right? So you did a good job, right? So important thing is again, just like in the history, you should not use medical terms, right? So I like the way you said food pipe instead of esophagus, right? So if you use things like esophagus, the patient won't understand, right? So you have to use things like food pipe, tummy, things like words that the patient is comfortable with, right? So now when it comes to breaking bad news, there are certain protocols that you would follow, right? There's something called the spikes protocol. So that's going to be discussed by Dr. Senator tomorrow. Similarly, when we are explaining a medical procedure like this, like an upper GI endoscopy, there are certain things that you have to do. So again, in every patient, introduce yourself, right? I'm a medical student or I'm a house officer, like that, introduce yourself. Confirm the identity. So are you Mrs. Pereira? Are you 50 years of age, right? Because if you go and take consent from another person, it's going to be a mess, right? So one of the important things when you are explaining a medical procedure is confirm the patient's identity. Again, ask the patient, are you comfortable in English, right? So those things you have to do, right? Introduce, confirm the identity, and confirm whether the patient is comfortable in English. And ask whether this setting is okay and whether he needs someone to accompany, right? Then before you sort of tell all the details and all that, you have to ask the patient's understanding. So, Mrs. Pereira, what do you think is going on? What do you think is going to happen? And the patient will say, I came with some bleeding, I was given some blood, now they want to do a procedure. That will give you an idea, right? That will give you an idea how to start, right? Because if a person, if he's like, I have done an endoscopy before, they want to do endoscopy again. Or for a person, I don't know, doctor, I came with some blood, now they want to put some camera in. So depending on the response that they give, you will know how to approach, right? So that is also important, right? Then you explain then only you explain the condition, right? So then you don't straight away say, I'm going to do endoscopy. Tell, so you come with some problems where we found that your blood levels are low. So we need to find out why your blood levels are low. So for that, we want to see whether there's some bleeding going on inside your food passage, whether there's any bleeding going on inside your tummy. The only way we can do that is by passing a camera. Then the patient will not get frightened. If you straight away say we are going to do endoscopy, patient might, it's a big word, patient might get scared. But if you explain why we are doing it, then it will be better. Then you have to explain the procedure. So what we are going to do is we are going to take you to the endoscopy room. It's going to be done by a surgeon who is well experienced in this. So we are going to give you some medication to numb the pain. We are going to put a spray into your mouth, which will numb your pain. Then we are going to put a camera, which is the size of my thumb, right? Usually it's like the size of the thumb. When we pass it, you will feel a bit uncomfortable. We have to tell the truth, right? We can't be over assuring also. Then next day, Mrs. Pereira will come and scold you. Doctor, you said no pain. I felt this pain. You said nothing is going to go wrong. This thing happened. So don't be too reassuring also, right? So you have to be realistic also, right? So you have to say, so you will feel a bit, I mean, everyone feels uncomfortable with an upper GI endoscope, right? So you will feel a bit under, but it's not going to take long. We'll give you some pain to numb it. We'll make sure that you feel as comfortable as possible. Then explain the benefits first, right? So this will give us an idea what's going on. If there's an ulcer, we can treat it. If there's a tumor, we can take a biopsy and diagnose it. And the possible complications. So like you very clearly said, there can be tears, there can be bleeding, there can be aspiration. So these things you have to clearly say. Don't tell that it's not going to happen, right? Again, then it's like you're over reassuring. So you can say, these are possibilities that can happen, but these are not very common. This is a common procedure that is being done and we don't see such complications commonly. But I can't guarantee you that it's not going to happen, but it's not a very common thing. That's what you can say, right? Don't say it's not going to happen, because again, if it does happen, this might be the 1 in 1,000 patient who's going to get a bleed, right? But if it does happen, then they will blame you for not telling. So you have to tell all the complications. And always give the alternative option. So you can be like you very clearly said, we can do something like a CT. But the problem is with the CT, sometimes things like ulcers will not be picked up. No? So because of that, this is the best thing. Then the preparation, right? So you would have to be fasting for 6 hours, right? So if it's a colonoscopy, you have to say how you are going to take those the laxatives, right? And always when you're talking to the patient, check back whether the patient is understanding. So Mrs. Pereira, did you understand what I said, right? Especially when you're giving a lot of information, keep checking with the patient whether the patient has understood, right? And if the patient has not understood, repeat it again, right? And encourage the patient to ask questions. So you have to be like, Mrs. Pereira, do you have any questions regarding this proceeding, right? Okay, and then you can answer the questions, right? So those are important, right? So even in the history, even in the communication, addressing the patient's concerns and seeing whether the patient has any problems and answering these problems is important. And then last thing is to get the consent, right? So don't start by saying, I want to get the consent. You do all this. And last thing is you're going to be like, so Mrs. Pereira, what do you think? Can I get your consent for the procedure? Got it? So, so we'll be doing a few more sessions like this, right? So I hope this is useful. We are still waiting for confirmation of how the the exact format is going to be, so that we can better tailor this for you. But this is what we feel. It's going to be things like this that's going to be there, right? So keep practicing now, right? Keep practicing. If you have any questions, drop a message on the group. We'll be more than happy to answer. So Dr. Senuru will be doing a very similar thing tomorrow, but he'll be covering different aspects, right? So I did things like procedures. He'll be doing things like breaking bad news. He'll be covering a different aspect of history taking, different aspect of examination, different aspect of emergency, right? So try to join his session as well, right? It's going to be useful. I hope today was useful. I hope you learned something, right? And all right. So let us know if you have any questions, okay? All right. Good night, guys.
Thank you, sir.
Thank you, sir.
Thank you, sir. Good night.
Night.